CURES is sponsored by Wheeler Health's Better Choice program. More at wheelerhealth.org.
Helping you lead a healthier life. This is CURES.
Hi, everyone. Welcome to the CURES Show, where today we are diving into the truth about hormones. We cover cutting-edge wellness here. I'm Kara Sundlin, and yes, cutting-edge hormone replacement therapy really could be helpful for women going through perimenopause and menopause. And here to tell us much more is Dr. Anita Petruzzelli. She's the owner and medical director of Body Logic MD in Hartford. Thank you so much for being with us, doctor.
And thank you so much for having me.
Just a huge response. I always know when there's a lot of folks interested, because I posted on my social media channels about like, which questions would you want me to ask? And so many people, just a huge response, because there's so much curiosity and there has been so much misinformation about hormone replacement therapy. So we're going to try to get to it all. I promise I'm going to ask as many of your questions as I can. But let's just start from the beginning. Do you think a lot of women are suffering through perimenopause and menopause and they don't have to be?
Absolutely. I think that there's so many women suffering from hot flashes, night sweats, vaginal dryness, pain with sex, decreased sex drive, movement and memory changes, and even unfavorable body composition like decreased muscle mass and bone density. There's, I think in 2020, there was greater than 63 million women over the age of 50. The average age of menopause is 52, and we have menopausal symptoms both many years before menopause up to 15, 20 years post-menopause. So that's a huge percentage of people in the United States that are suffering, because right now in 2023, only 1.8% of women were on hormones.
Yeah, and let's just talk about, there was a huge study, and there was this belief of, oh, you can't take hormones, you're gonna get cancer, or I have breast cancer in my family, I'm out. This old information is now being proven inaccurate, but it's not exactly filtered down to practitioners yet, right?
Correct. So in 2002, 2004, there was a Women's Health Initiative. It was this large multi-million-dollar study that was going to answer the question, does hormone replacement decrease chronic disease? So it looked at about 16,000 women, and they gave them either estrogen, synthetic oral estrogen, synthetic oral progestin if they were just normal menopausal women, synthetic oral estrogen if they were just, if they had a hysterectomy. And what they found, they stopped the study after 5 years and 7 years because there was an increased risk of breast cancer, heart disease, stroke, and blood clot. The actual numbers were very low. And again, this is 2002, 2004. But the women that they looked at, the average age was 60, so it's 10 years postmenopausal. So fast forward, researchers have been looking at the different groups, the women that were just on estrogen versus the women on estrogen and progestin. And what they found is that women who were under age 60, if you started hormones in the first 10 years of menopause, you had less heart disease and less death due to all causes.
Okay, so let me just back up. Before, they were studying women who were older, who were beyond or kind of postmenopausal, age 60. Now, what they found is it's sort of the reverse. It's protective if you start before menopause, or especially in those years leading up to it.
In the first 10 years of the onset of menopause or under age 60, it seems to be most beneficial. Now, I always have to say the FDA does not approve it as primary prevention, but there's a lot of studies out there looking at primary prevention and secondary prevention of hormone replacement, but it does appear to be beneficial and less heart disease risk for people that are at low risk.
So you obviously need personalized medicine, and we're going to get into that because there's certain tests you want people to have. There's different ways of taking these hormones. But fair to say right now, when you're going into your regular doc, and I love a lot of my regular docs, but you're saying when you were going to med school, they didn't even talk about menopause. I mean, there's a lot of doctors who are just like, yeah, I know this is aging, and they're not really offering solutions.
So that was about 30 years ago or so for me with med school. But I think we had one class, and you were taught as an OBGYN resident to take care of normal, healthy women, not menopausal women, even though such a large percentage of our life is going to be spent in menopause. So you do have to keep up with all the research, and there's research that comes to my cell phone every day based on hormone replacement and other, heart disease, breast cancer risk, and I've done a lot of extensive learning with other organizations like the American Academy of Anti-Aging Medicine.
Yeah. So talk to me a little bit about your journey. First of all, our audience, I just want everyone to know, because you said this was okay.
Yes.
You are 13 years past your menopause. You are 60 years old.
Correct.
Obviously, you're in great shape. You look young, great muscle tone. All of that. Has this been part of your own personal journey to get yourself good care?
I would say yes. Our family went through an early menopause. And I had patients that were menopausal that were on hormones. And so when the Women's Health Initiative came out, they didn't want to stop their hormones. So I started researching and saw that the American Academy of Anti-Aging Medicine talked all about research for hormones. And I took every course they taught.
So you need a menopause-informed practitioner. A lot of people on my Facebook page were asking, how do I get a doctor who knows how to do this and knows if I should take them?
So you want somebody who probably is an OBGYN or an endocrinologist, or could even be an internal medicine doctor that's done extensive research in educating themselves and keeps up with the daily research on menopause treatment. There's a North American Menopause Society in the United States, the American College of OBGYNs, the Endocrine Society publishes information. So all of them have guidelines, and then there's other organizations like the American Academy of Anti-Aging Medicine does additional teaching.
Yeah, and I just want to let everyone know that Dr. Petruzzelli is here, and before you're thinking, oh, I'll never get in with her, you actually are taking new patients.
I am taking new patients. I also have virtual nurse practitioner and physician's assistants that work with me too, because it is a while to get in to see me.
Okay, but there are people like nurse practitioners, sometimes these could be virtual appointments, sometimes, I mean, the initial, a lot of what you might need to start with is some testing, right? Like, where do we start to find out what's best for us?
So when people come to see me, they have about a 13-page online questionnaire that's going to be very detailed with their medical history, their family history, medications, surgeries. Do they have risk factors for hormones like do they have elevated blood pressure, elevated cholesterol? Are they diabetic, pre-diabetic? Do they have a personal history of blood clot in their legs or lungs? Do they have a family history of heart disease or stroke, family history of breast cancer, family history of anything that's going to be concerning that puts them at risk? I'm going to get a full symptomatology. And they actually get blood work before they come to see me. So they're going to get blood levels for estrogen, progesterone, testosterone, DHEAS. I'm going to look at their cholesterol, metabolic panel, their thyroid, their vitamin D, some inflammatory markers. If they're, if they have a uterus, they're going to give me a pap smear. I'm going to have a recent mammogram. So I want every bit of information I can. And then I spend about an hour calculating risk for them. So I will look at their breast cancer risk, their heart disease risk.
Okay, so there are a lot of tests you need, and will this be covered by insurance, at least the testing part?
The testing can be covered by insurance. I'm a cash practice, so you could use flexible spending or health savings.
Yeah. If you do have some of these risks, I know people right now are going, oh yes, my mother had breast cancer, or my sister did, or does that mean I can't take it? What I've read is that just because you have some certain things in your family does not preclude you. In fact, it still may be beneficial for your long-term health to go on hormones. Is that right?
So that's a really good question. That is correct. So I do an individual risk analysis. So for instance, if you have a strong family history of heart disease or stroke, and say maybe you come in and you have high blood pressure and your cholesterol is kind of elevated, I might recommend a coronary calcium score, which looks at plaques around the arteries in your heart.
I've had that.
You've had that.
For
I've
a
had
story.
that too.
Yeah, for a story. We did it. In fact, they're only $99. They're not covered by insurance.
Perfect.
But they're really, at least when I did the story, they recommended everyone get those. And you can see, and then you know if it's going up or down.
And I think that's perfect because, I mean, heart disease is the #1 cause of death. It affects 300,000 women die annually of heart disease, so it's something preventable. So if people don't have a coronary calcium score, I'm going to calculate a Framingham risk when they come in. If they have a coronary calcium score, we deem it necessary, I'm going to calculate a MESA risk, but cardiologists have other risks. If your 10-year risk is less than 5%, then you're a candidate for hormone replacement. But obviously, if there's something concerning, I'm going to send you to a cardiologist. But I calculate these every day, and I rarely ever see a woman with an increased risk under age 60.
Okay, so age matters. I had a lot of people ask, what is it too late for me? I'm already 60.
It would depend when you went through menopause. Some people go through menopause 56, 57, 58, but if you went through menopause, say 45, I would calculate your risk and find out what your symptoms are and what we need to accomplish for you, and then it would be a risk versus benefit.
Why is it more risky for older women to start replacement therapy?
I think the concern is that even though estrogen seems to stabilize plaques, there's some thought that after age 60 it may not do the same thing.
Does that mean younger women like myself, who if you're going through perimenopause and menopause and you want to go through hormone replacement therapy, do you eventually have to get off of it, or do you stay on it?
You can stay on it as long as you're being monitored. The American College of OBGYN and the North American Menopause Society used to say you need to come off at a certain age, like 60, 65. Now their statements are you can stay on it for symptom relief, looking at risk versus benefits. So I have women in my practice in their mid-80s still on hormones.
Yes, well, there's a book that's making its rounds on Instagram right now. Who wrote the doctor, Dr. Marie. I don't want to get her last name wrong, but she wrote The New Menopause. She's kind of everywhere. And she said, I listened to a podcast with her, and she said, I'm going to die with my estradiol patch on.
I hope so, too.
Yeah, that's how you feel. Okay.
I do, too.
And people are going to say, why? I don't have hot flashes anymore. I think what people don't understand is hot flashes are only one of the symptoms, right? There's a lot of other stuff going on that's related to menopause that we might be blaming on other things.
Yeah.
Like moods.
Absolutely. So, I mean, I think the vaginal dryness and pain with sex is a big one because people don't tell you that that's going to happen to you. And as an OBGYN, people would say, I have no flashes. And I would say, just wait a year or so. You may want to start your vaginal, preparation for vaginal dryness now because it's only going to get worse. That doesn't get better. And I would say about 50% of my patients have to use something for vaginal dryness, even if they're on systemic hormones. So that's a big one.
Okay.
I mean, even estrogen helps collagen and elasticity in your skin.
Does it help us just talk about vanity. Does it help us with wrinkles?
I would say yes, because my women on hormones always, to me, look like they have nicer skin. I mean, it would be better if they didn't smoke. So, smoking's going to make your skin worse, but estrogen definitely has collagen and elasticity benefits. I mean, estrogen can help your eyes. It can help, eye pressure, against macular degeneration. It's protective of colorectal cancer. It's protective of osteoporosis.
Yeah.
In terms of mood and memory, it's a little controversial. So I would say it's mood lifting and mood elevating for women that are not clinically depressed, or if women start hormones, like if they have their ovaries removed, it seems to help mood. Cognition is the same thing. In the Women's Health Initiative, people were taking it later. They saw more dementia. But if women start it earlier, like after their ovaries are removed with a hysterectomy, it may be beneficial for cognition. So there's a lot of
So we're learning timing really matters.
There's a lot of timing, and a lot of these studies, we need more studies, but there's so many. Estrogen has 300 functions in the body. So there's so many things it could do, but I think it could help hair, but we don't have research to substantiate that.
Okay, I just want to, if you're listening and going, well, I want that book, it'd be great if you write a book someday, but The New Menopause, Dr. Mary Claire Haver, and that is, thank you so much, Jamie, who was looking that up. I didn't want to get it wrong, but I've been listening to her. She's popping up everywhere, and basically she said she had such a horrible perimenopause, menopause experience, and she was a doctor and she didn't know how to treat herself. So she went and kind of did what you did and just really devoted her life to learning about something she said they're not teaching enough in med school. It might be changing. It's starting to trickle down, but a whole generation of women were kind of maybe left in the dark. They all were told to get off their hormones, and we're learning now that maybe wasn't the best thing. So let's just talk about perimenopause for a minute, because a lot of questions were, should I start this before I'm in menopause? And I do have some friends who are reading about this and saying, I don't want this to happen to me. I want to be optimal. I'm starting hormone replacement therapy now before I actually fully hit menopause. Is that recommended?
If you're having symptoms that are consistent with hormonal decreases, so people may start to have hot flashes, night sweats, some sleep disturbances, vaginal dryness, and your hormones. So there's no, I'm going to say, I look at hormone levels. I've been looking at hormone levels for 30 years. It's a range. There's no acceptable, really,
Okay.
like perimenopausal. But, you know, you want to make sure if you're having hot flashes and night sweats or you're feeling depressed or lethargic that it's not your thyroid, for instance. So you do, you know, I have a lot of women who come in and their B12 is low and they're anemic, and and you give them that and it's not their hormones. So you do want to look and see.
So you want a full panel.
Yeah.
So if you're going to go and ask your doctors, again, Dr. Petruzzelli is taking new patients here, but if you're going to ask your doctor for a panel, and say, I want you to work with me on this, you recommend, as someone who's done this for 30 years, what are the kind of basic tests you want to see first?
So I want to, you know, make sure there's no contraindications. So I am going to do a complete metabolic panel. I'm going to check their blood sugar and check their liver and kidney function. I'm going to look at their cholesterol. I'm going to look at their thyroid. I'm going to look at their iron and ferritin levels. Then I'll look at estrogen, progesterone, testosterone, DHEAS. I also do a urine cortisol, which is stress hormone.
Okay, right. Can you take hormone replacement therapy if you're also on other medications, or are there certain medications that you just can't?
I would say, you know, the contraindications would be if you have a history of breast cancer, maybe uterine cancer or a hormone that is cancer that's hormone dependent, liver disease, gallbladder disease, history of a blood clot. So those would be things that are personal history of heart disease and stroke. So those would be probably indications. So you might be on medications for those things, but it wouldn't be like you can be on a statin. Hormones seem to help decrease like the risk of diabetes. So even if you're diabetic, it doesn't mean you can't be on hormones, but we're going to get your endocrinologist involved or your cardiologist involved in the decision.
Well, the other thing is one thing that people don't talk about enough, which we've done shows on this, is women, when they're going through perimenopause and menopause, we start gaining weight, and part of that is linked to that estrogen's going down, right? So will it help with weight loss and making our body composition like what it used to be, or in that direction?
Yeah, you know, it's a really good question, and I think it's more a testosterone and growth hormone component of this. But there are some studies that estrogen in conjunction with exercise can give you a favorable body composition. So I think our ovaries and our adrenal glands make testosterone, and it slowly decreases. And I think coupled with that, you know, you're losing your muscle mass, so your body's less efficient. You know, with low testosterone. So I think it's the testosterone level why my patients always say to me, you know, I'm exercising and eating healthy and I can't shift my body weight.
Right. But so now we've talked about estrogen a little bit. So the forms of how you would get the estrogen, would you take it in a cream? Do you take it in a patch? And what's the difference between, say, I'm going to get the estradiol patch that's covered versus go get something bioidentical that might be made by a special pharmacist and put in a cream?
So I'm going to say I'm in favor of the patch. The patch is bioidentical, so everybody knows it's bioidentical. You can use GoodRx. I hope I could say that on TV.
GoodRx, bioidentical, as in the estradiol patch.
Right, and GoodRx, like even if you don't have really good health insurance, your GoodRx card will get you at a pretty decent price. It's been studied, you know, for safety, for efficacy. You put it on once a week or twice a week. With a topical, like a cream or a gel or the patch, it's going to be the safest for you, so there's less risk of blood clot, less increase of blood pressure, less adverse effect on triglycerides and lipids. It has less carb cravings. It doesn't decrease your testosterone and growth hormone as much, and it doesn't. It keeps inflammation in the body down. So there's so many beneficial reasons to use topical that there's no need to give an oral, even if it's just based on blood clot risks. I don't give anybody oral.
So the estradiol patch, is there a certain dose you start at?
It really just depends. I'm very conservative. Most people get started on the lowest, and we just increase until we get them to the dose that they need that covers their symptoms without any side effects.
Okay, so you would actually put them on a patch. I think it starts at the lowest of like
0.025 and goes up to 0.1.
Okay, and you would keep moving them up till you got a level you wanted to see?
And I would check blood levels because there is a range, but the range changes the day after you change the patch to the day you've changed before the patch. So I would also have patients, if they're really symptomatic, tell me when they're changing the patch when I look at their blood work.
Okay, so just to know that the patch, you put it on, you generally would switch it. It's very tiny, it's clear, you put it on and you change it.
Every 3 to 4 days.
Yeah, twice a week. So then you also can't, I've heard, take that alone. You need
Correct.
progesterone. You can't have unopposed estrogen, or that's dangerous, right?
And this is probably the most important, like, so I hope everybody takes this
Don't
home.
take estrogen alone, or you're risking a lot of things.
So you would have an increased risk of uterine cancer if you have a uterus. If you don't have a uterus, this doesn't apply to you, but if you have a uterus, you have to use oral progesterone or progestin. You can use vaginal, but just topical on your skin does not protect your uterine lining.
Okay, so it's usually a progesterone pill, 100 milligrams about?
100 milligrams, 200. This is micronized oral progesterone, bioidentical. The pharmacy has it. If you needed something not 100, in between 100 and 200, you could compound it.
Okay, so we're going to take a quick break and hear from our sponsor. We're going to come back with even more of your questions, and such good information so far. So just pause for a second, doctor. Thank you.
Struggling with gambling? Wheeler Health's Better Choice program offers personalized support and treatment to help you regain control. Visit wheelerhealth.org to learn more and take the first step towards recovery today.
All right, we are talking about hormone replacement therapy. It is something that so many women have questions about. And I'm here with Dr. Anita Petruzzelli, who has devoted the last couple decades, at least, to researching this.
I would say I've been an OBGYN over 30 years,
Okay.
but I've been doing this as a specialty for 15 years.
For 15 years. And that's really all you do, is help women with hormone replacement therapy. And why would you tell someone, I'm not doing it for you, you shouldn't have it?
If they have a strong family history of breast cancer, they have a personal history of breast cancer, but I will get back to this. They've had a blood clot in their legs or lungs. Those might be reasons that I would not give it to them. They may be candidates for testosterone. They may be candidates for other hormones, but probably not estrogen. In that case, like if you have a history, personal history of a blood clot in your legs or lungs, I've had patients do hereditary clotting factors, see their hematologist, and their hematologists have actually, I'm not saying this for every hematologist, but I've had hematologists say it's okay to be on a topical estrogen preparation because it causes less blood clotting. So it just depends.
So let's just talk about basic pros and cons. The reason why you might want to be doing this is you probably have some symptoms, and you might not even realize that you're suffering from perimenopause or menopause. So what would be some of the symptoms that could be addressed by hormone replacement therapy?
So definitely hot flashes, night sweats, vaginal dryness, pain with sex, sleep disturbance, mood and memory issues, and even
Like brain fog.
brain fog.
Yeah, that's what people say. They're just all of a sudden like, I can't remember this person's name, or I'm feeling really low energy, really sluggish. I'm snapping at people more than I used to be.
Irritability.
Irritability, okay. And sometimes if you mention that to your primary care, they immediately put you on an SSRI. What's your thought on that versus hormone replacement therapy? Could hormone replacement therapy help you more?
It depends on the cause. If it's menopause, hormone replacement therapy is probably going to help you more than an SSRI or even some of the ADHD medications that people come to me because they can't focus or they're not sleeping, so now their energy isn't good.
Yeah.
So SSRIs can be used to treat menopause, but I still think hormones have more benefit if you're the appropriate candidate.
What if you're already on an SSRI for some sort of thing? Can you take hormones still?
Absolutely.
Okay.
Absolutely.
So this is a very specific question, but I wanted to ask it for one of our viewers who wrote on Facebook. Are there any known complications for people with the MTHFR gene mutation? My aunt had a stroke with hormone replacement and the mutation, but I don't know if anything is known about a crossover.
So that is a genetic trait that has to do with the metabolism of B12 and folate. For most people, it doesn't put them at an increased risk of a blood clot or stroke, but it's possible her aunt has either prothrombin gene or factor V Leiden, which are hereditary factors that could increase the risk of a blood clot. So if you were tested, so if you said my aunt or my mother, my father, my sister had a blood clot, had a stroke, had a blood clot in their legs or lungs, I would get clotting factors checked and get a hematologist involved with this decision.
So another one writes, I've heard so much about the side effects for years, but I'm in the thick of perimenopause and I really don't like it, and I've begun to consider HRT. If you're suffering from these things of insomnia, irritability, all the other things you mentioned, should you be considering HRT?
I would say yes, as long as you don't have a strong risk. And if you don't know what your risk is, you can calculate it. Because even like the insomnia, taking bioidentical progesterone, the micronized progesterone from the pharmacy, it's bioidentical as opposed to the synthetic, is going to help with mood and irritability. It's going to help with hot flashes and night sweats, and it's going to help with sleep. And we used to give it to pregnant women to prevent miscarriage, so it's very safe.
Okay, wow. Okay, so the same progesterone you might be taking in the pill. Is it okay to call it progesterone, same thing?
So the 17, or the micronized progesterone, so it's progesterone, but progestins is probably like synthetic. So progesterone, progestin, it's all, it's kind of the same. We can talk about it like that.
Okay, so number one, you don't want to just go and start taking this. I don't know if you can just get it online, but you should.
You can get cream online, I think, without a prescription.
And do you recommend that?
I don't.
Okay.
I mean, I don't think it's harmful, but it's not going to protect your uterine lining, so you want to be careful.
Okay, and the current, regular old thinking was just stay on the pill. You can stay on the pill till you're 50, no problems, or, that'll help get you through. Can we do better than that, or why wouldn't you do that?
I mean, if you need birth control, the pill is still really safe and effective, and it does have, I always say it's got beneficial effect. It's going to protect you from being anemic. It's going to protect you from like ovarian cancer. It's going to help you with acne. So there's some benefits to being on the pill. So I don't want people to think they can't be on the pill, but it can raise blood pressure. It can cause clotting issues. We don't know over age 50 how safe it is. There could be better things if you don't need birth control. And I mean, you could use other methods of birth control too.
I can't believe we're down to the last 2 minutes, but we've actually talked about that we would maybe do a Facebook Live and take your questions in the future, so I'll work on that. But I want to get to your point of testosterone is the best kept secret of menopause, you say. I haven't read a lot about testosterone, and I don't know if I should be taking it, but why do we need testosterone also?
So our ovaries and our adrenal glands make testosterone. It decreases as we go through menopause, and it helps with mood, with drive, with focus, with energy, with concentration, with hot flashes, night sweats, vaginal dryness, sex drives, protects our muscles, protects our bones, can help with joint pain, can even help with patients who have like essential tremor. So there's so many benefits. My patients who I give testosterone to say it's life-changing. That's what makes them feel normal, especially my patients who've had hysterectomies.
So we're going to have to end it soon, and I want to let everyone know that Body Logic MD is in the Hartford area. It's located in Glastonbury. Shout out your website so that people can find you.
DrAnitaMD.com.
DrAnitaMD.com. So in our final minute, can you give me a roundabout, like approximate percentage of women you think would benefit from HRT?
Well, it says that 75% are suffering, so probably about 75% of women
75%.
would probably.
And only 1.8% are doing it.
Correct.
There's a lot of room for improvement.
Absolutely.
A lot of education that needs to happen. Yeah. Dr. Anita Petruzzelli, I know you, so many more questions. We could talk all day, and we'll find another way to do more. But thank you for sharing this knowledge, and I want you all to know that she is reachable either herself or on her team to get the testing and the care that you deserve. Thank you so much.
Thank you so much.
Have a great day, everyone, and be well.
CURES is sponsored by Wheeler Health's Better Choice program. More at wheelerhealth.org.